All right, let's look at radiographic criteria of a chest x-ray. All right, so whether it's an AP chest x-ray or a PA chest x-ray, we have to make sure that we've completely traversed the patient's body from the front to the back or from the back to the front. All right, so let's look at these. I'm going to highlight the different pieces of anatomy that we're looking for on this chest x-ray, as you know, and that way we can compare it to the way it looks anatomically and the way it looks radiographically. So first thing I'm going to do is hide the sternum, because if you look at the chest x-ray, you can see that the technique is set so that that sternum, because it's such a small a flat bone, and it's made most of cancellous spongy bone, that it gets penetrated and then it doesn't show up on our chest x-ray, which is fine with us because that's not what we're looking for. We're not looking for bones, right? So what we are looking for, the first thing they've highlighted or labeled on the x-ray is the trachea. We always look to see where the trachea is. The trachea should be centered on the x-ray. You know, if a patient has a type of some type of pathology, which is some of the things we're going to talk about later, that they may have what's called a midline shift, where the trachea may be shifted to the left or the right, depending on whatever some type of pathology or condition the patient has. But the trachea should be centered. We will see because the spine is behind the trachea, we will see the spinous processes, these spinous processes superimposed through the trachea on our x-ray. So that's something that we'll be looking for. You know, we'll see those spinous processes centered through the trachea. We'll also be able to see the shadow of the spine through the heart muscle too, because those structures are superimposed over each other. All right, now working our way down the trachea, let's look for this the carina. All right, this is where the carina is happening here. The carina happens at the level of thoracic vertebra 5 to 6 in our body. So this is where the trachea bifurcates into the right main bronchus and the left main bronchus, and it's called the carina or carina. You may have heard it called the carina. And then also we will look for on our chest x-rays what's called the hilar region. The hilar region is where you see all of these. We see the pulmonary vessels over here. We can also see, you know, those bronchi, right? Those the branches of the bronchus. So also the pulmonary vessels, right? So the hilar region, they define the hilar region as the area where the great vessels, those pulmonary vessels, are entering and exiting the lungs. They call that area the hilar region. That's why it looks really like we have all these little opacities happening on the chest x-ray in that area. It's because we're seeing these little structures, all these vessels and things. Also the pulmonary trunk here, right? So we'll be able to see the pulmonary trunk over in within the hilar region. So they've labeled the right hilum and pulmonary artery all as one thing on that chest x-ray. You know, we just need to know that we've penetrated through the heart, because you see how those things are behind the heart here. We need to make sure that we've penetrated so that we can, you know, demonstrate the hilar region and that pulmonary trunk for the doctor so that they can look at it more closely and identify that, you know, those anatomical structures look normal or abnormal, depending on what the patient's going through. So, but for us, it's our job just to know that we've penetrated through it and that we can see it, and that it's there for the doctor to be able to diagnose if something's wrong with it. All right. I kind of shaded out the lungs here so that we could see those things. You know, that's why we can see those different structures in our X-ray. Okay, so working our way down. So I talked about the trachea, the bifurcation of the trachea called the carina. Talked about seeing the spine through the trachea, also seeing the spine through the heart muscle. Now we're down here at the diaphragm. So we can utilize a diaphragm to identify where the base of the lung sits on the diaphragm. Now we have the angles that we look for to make sure that those angles of the lungs are so important, because if a person is standing up in an erect chest x-ray for us, we are going to be able to see if there's fluid in the lungs. by looking at those corners, because that's the most, those costophrenic angles are called costophrenic angles. Costo is the medical term for rib. All right, so the angle that's more laterally near the ribs on the lungs is called the costophrenic angle. Now, the angle that's closer where the lungs sit against the diaphragm near the cardium, the heart, cardio means heart. Medical term for heart is cardio. So they call that the cardiophrenic angle. All right, so the cardiophrenic angles will be medial towards the heart. The costophrenic angles will be lateral towards the border of the ribs. All right, the costal margin. And then we got the big diaphragm, and we'll be able to see, the gastric bubble. The stomach will be up here right underneath the diaphragm on the left. We'll see a little gastric bubble happening there, and we'll be able to see some gas patterns and stuff depending on how much we have below the diaphragm. We really should just get to right below the diaphragm to the costophrenic angles and not expose the patient's abdomen. So we will see the little gastric bubble of the stomach, but that's really all the abdomen we should see in our image. Okay, so I hope this was helpful for the criteria, looking for those anatomical structures, and just remembering that we're looking at structures that that are kind of pancaked together on our image. So we've got the heart kind of pancaked into those pulmonary vessels, those the heart, the pulmonary vessels, the trachea, the esophagus, all, then we've got the vena cava, we've got the aorta. There's a lot of things that I've taken off of this image to show you the things that we're looking for specifically on the chest x-ray itself. And then also keeping in mind that that spine will, if we penetrate all the way through, then we should be able to see the spine, a shadow, at least a shadow of the spine through the heart. That lets us know that we use the right amount of kV for our technique. Now, if we do use too much mass on our technique, what's going to happen is we're going to burn out these little tiny vessels. These little tiny vessels on our x-ray should be what we call them lung markings. So these little vessels that we see out, out in the lungs, even like the vascular, when I took it away, like there's all these little vessels in the lungs. If those little tiny vessels are burned out or too dark, that means that we use too much mass in our technique. So that's another thing to think about with your controlling factors for that. Also, let's look at the ribs for a second. I didn't talk about the apex of the lungs. The apex of the lungs. So the apex of the lung is the top of the lung here. So I like to highlight that first rib. I look for that first rib on the x-ray. So if you can find that first rib, it's short and curved, and it kind of curves around that apex of the lung. So that's a good way to find the apex of the lung as well for your x-ray, because we've got to make sure we don't clip that apex. Clavicles we will use for rotation. So I'll do a different video for that. All right. Hopefully this was helpful. Thanks for watching.